Really a pleasure to be here. I'm going to talk about some of the current guidelines for surgical site infection prevention. I've gone through and I hopefully modified my presentation to focus principally on orthopedic issues today. I'm going to go through a brief introduction of the concepts of surgical site infection prevention, and I'll go through that fairly rapidly, and then I'm going to get into some of the more detailed and specific considerations that I think affect you in orthopedic surgery. I have no conflicts of interest, and I'm going to skip my professional practice gaps and learning objectives, but they're in my presentation, and I've made my slides available to your team that can certainly be distributed. So, surgical site infections, still the most common healthcare-associated infection in the hospital setting. Affect a lot of patients, and of course, I probably deal with surgeons like colorectal surgeons a lot more commonly because the risk of surgical site infection is so great in some other types of operations, but they're very, very costly. And let me be absolutely clear. I understand the devastating consequences of surgical site infection in the orthopedic population. So prevention is incredibly important in your population. When they happen, when you guys see patients with surgical site infections, prosthetic joint infections, the implications for the patient are enormous. The cost of care are enormous. And I think we're going to see a lot more periprosthetic and joint infections in the future, and I'll show you why in just a moment. Remember that when we talk about preventing surgical site infection, there is no magic pill because there are all sorts of different risk factors that impact the risk of a patient getting a surgical site infection. There are a lot of those host factors that we just don't have control of. So you'll have patients who have need for orthopedic surgery that are diabetic, have cancer, they're on immunosuppressants because of their rheumatoid arthritis. They're sicker patients, they have higher ASA scores and things like that. We can't control a lot of that, and oftentimes, the surgery is semi-urgent or others, and so you don't have the ability. One of the things I'll spend a little bit of time talking about is that some patients are colonized with bacteria that can cause infection, and how do we deal with that? There are a lot of unknowns here, but I'll spend a little bit of time talking about some of the endogenous floromicrobial factors. There are surgical procedures, clearly orthopedic surgery, we expect relatively low surgical site infection rates, but there are certain factors with the surgery that can affect you. So hemostasis, I know, is an enormous concern for orthopedic surgeons because blood clots in the wound are not a good thing in terms of trying to prevent infection. And then lastly, all of those things that us, the entire perioperative team, have the ability to control, things like giving prophylactic antibiotics, doing appropriate skin prep, screening for those endogenous microbiology factors, things like that clearly have an impact on rates of surgical infection. And some people don't like hearing me say this, but I've been to a bunch. I was at the University of Kansas not long ago where they really have this big focus on chasing zero, and they're targeted zero surgical site infections. And I'm not sure today we have the current scientific knowledge to get there, to zero. But we want to prevent the ones that we can prevent and get the rates as low as we possibly can. So just a couple of the, Dr. Lee from Minnesota used to talk to me about this. Some observations about surgical site infections. Recognize that when you cut through the skin in the operating room, there is no such thing as a sterile operating room. We clean it as much as we can, but it's not sterile. The skin, we often cleanse it, use bactericidal agents like alcohol, chlorhexidine, and others on the skin, but it's contaminated with bacteria. So most surgical wounds have some bacteria that get into the wound. That's actually relatively common, and you can culture wounds and find that in the operating room. However, most patients don't get an infection, luckily, and that's because host defenses take care of those bacteria that get in there. We can enhance that, though, by giving antibiotics, by controlling blood sugar, by keeping patients warm, by perhaps giving patients additional oxygen. Similar operations performed by the exact same surgeon but in different patient populations will result in different surgical site infection rates, and that goes back to my issue here. There are a bunch of host factors that are very different for each patient, so each patient's risk will be somewhat different. And obviously wound infections have varying degrees of severity. I'm not going to go into the differences between the deep infections and superficial, but clearly we're most concerned about the deep ones. The other thing is bacteria get into the wound from lots of different ways. Now this is a representation from colorectal surgery, but yes, there are bacteria in the air, and that's been well demonstrated, and we do things like laminar flow and other things to try to prevent that, but there are bacteria in the air. Certainly if you go into the belly and get into the colon, you release a lot of bacteria. The risk of surgical site infection skyrockets at that point in colorectal surgery. But guess what? The team around the patient drops bacteria. It's been demonstrated multiple times. The exact amount of contribution to infections is not known, but it doesn't contribute. Anesthesiologists can carry infection from room to room. That's been demonstrated that if they're not doing appropriate hand hygiene and other things. There have been studies that have shown that the infection in one room that they've been working with the patient, the anesthesiologist going to another room can actually transmit that infection to another patient in a different operating room. So hand hygiene is incredibly important for anesthesia also. So lots of different ways that bacteria can get into the wound. Those of us that are purist about surgical site infections believe that most surgical site infections start in the operating room. That's when the wound gets contaminated, somewhere in the operating room. The other thing to highlight is that the wound space is an ideal place to grow bacteria. It's avascular because we've often cauterized around it. We don't like blood clots in wounds, so we stop bleeding and things like that. We also suture around the wound or put staples that actually compress blood vessels. So it's a relatively avascular space. It's hypoxic, but it has interstitial fluid and other things that like to grow bacteria. And that's part of the problem with the delivery of post-closure antibiotics. They won't get there into that surgical space. And so there's a reasonable chance of surgical site infections. Well, what about orthopedic surgery? Total joint arthroplasty is the most common operation done in the United States today if you look at hospital inpatient operations. And I know we're starting to move some of those procedures now to the outpatient setting. If you look at the Medicare population with whom I deal with the most, it is by far the most common operation. I think the other thing, though, when we were writing the CDC guidelines, we noted that there's probably going to be an explosion over time of number of revision joint arthroplasties you have to do. Let's think about it. Patients are living longer. You've been doing arthroplasties in your institute for many years. Some of those patients are eventually going to have revisions for loosening or other reasons. And the risk of infection in revision surgery is much higher than it is in the native surgery. So we actually expect the number of prosthetic joint infections in the U.S. to go up by 2030. It was predicted that the risk would go up to about 6.5% in some series. We already know that the number of operations is going up dramatically. The total number of infections has gone up, as well as the overall cost. It's expected by 2020 that the U.S. cost for periprosthetic joint infections will be $1.6 billion in the United States. Again, I'm all for targeting zero, but part of this is going to be related to some of those host factors for which we sometimes simply don't have control. And we expect to see over time, you're going to be doing more revision operations and other things for patients that did very well for years with their joint arthroplasty, but for whatever reason need to have a revision. Well, what are the bacteria that cause joint infections or cause surgical site infections in orthopedic surgery? This is data from Robin Patel's group, the Mayo Clinic, that not surprisingly, Staph aureus and coagulase negative staph are clearly the most common organisms that cause surgical site infections in these patients. So whatever we do, we have to make sure we're covering staph, both coagulase negative, MSSA, MRSA, and the Staph aureus. Streptococcus species, and then you see a smattering of others. I'm going to come back to gram-negatives in a moment because surprisingly they're more common than we sometimes like to recognize. Cutibacterium, one that's become a problem, particularly in shoulder surgery, is an organism that we didn't used to be too concerned about, but we are now, particularly with shoulder arthroplasty. And then a certain proportion of patients who get prosthetic joint infections, we don't ever diagnose the cause. I was at this very, very good presentation. I don't know if Philip heard Robin Patel give her talk on periprosthetic joint infections, but she actually presented a case of a patient that had a mycoplasma periprosthetic joint infection. There are a host of organisms that they've found in these infections that are very difficult to treat and also then end up with recurrent infections. This is also Patel's data, again, showing that when you look at monomicrobial versus polymicrobial, if it's polymicrobial, staph epidermidis is almost always a part of it, and then of course 22% of the time staph aureus will be part of the organisms that cause the infection. So clearly the focus of our prophylaxis is going to be to target the gram-positives first, but I'm going to keep in the back of your mind gram-negatives just a little bit for some patients. Well, I've had the pleasure and honor over the years to work on a bunch of different guidelines. These are the ones that I've actually been an author on. As Phil noted, this past week we spent hours starting the update to the 2013 guidelines on which antibiotic you pick when the patient goes to surgery. But the Shea Compendium is also being updated. We haven't fully started that process, but it will soon. So both of those guidelines are going to be updated. When I led this team that published this in 2013, this past year I was in Geneva at the World Health Organization, and I came back to the United States from that meeting and said, we need to make sure that we don't let that guideline get out of date, that we keep it contemporary. So the 4 societies that wrote it are working on it. And then we just recently published the CDC guidelines in 2017. I've also reviewed, obviously, I know some of the controversy with the American Academy of Orthopedic Surgeons around some of the recommendations we made in the CDC guideline, and so I am quite familiar with those documents also, and have had the pleasure of working with many representatives from AAOS over the years. So I'm going to just hit a few highlights from some of these guidelines, and then talk about some of the things that are orthopedic specific that I hope generates some discussion. So when we wrote this guideline for which antibiotic do you give to a patient going to surgery, it was put together by 4 different societies, and those 4 societies have agreed and now are contributing to the updated guideline that we are working on, hopefully over a year or so to update. But we pulled together multiple organizations. The document's quite long. I will tell you there's only a few of us in the nation that have read the whole guideline. It's 80 pages long and has 1,000 references. But just a couple of principles. Number one, in almost every single study, in fact, very few that don't, show that if you give an antibiotic before a patient goes to surgery, you can reduce the risk of infection, even if the infection risk is really low. Giving an antibiotic before the patient goes to surgery reduces the risk. However, there are some operations where the risk is so low, or even if they get an infection, the consequences are not terribly significant, that it doesn't make sense. You'd have to give a whole bunch of patients antibiotics to prevent a few infections that might be just superficial cutaneous infections that we don't think are so bad. Some infections, the infection rate is so high that it would be criminal not to. So colorectal surgery, where most clinical trials show infection rates are anywhere between 15 and 20%. Versus orthopedic surgery, where I suspect you have rates that are 2% or less. I think they're underreported, by the way, but across the board, you would expect very low risk. But the consequences of an infection in orthopedic surgery are so high that we always give prophylactic antibiotics before the patient goes to surgery. So it's no easy decision about not every operation needs them. You have to weigh the risk of the infection, the consequences, the cost of the antimicrobials to both the consequences of an infection if it occurs and the actual rate of infection. One point I'm going to make and keep reiterating, beta-lactam antibiotics are typically the antibiotics of choice for prevention of surgical site infections. we way overuse vancomycin in particular. This is from the American Academy of Allergy, Asthma, and Immunology that shows that 90%, 10% of the entire population that you see, if we go upstairs and look at the charts, will say that they're allergic to penicillin. They'll tell you that when they come in. 90% of those patients have no penicillin allergy and can take beta-lactams quite safely. It turns out that if they report an allergy as a child, they may actually have had an allergic reaction as a child. But the more years that are between that and the subsequent surgery, the risk of allergic reaction is very, very low. In a lot of studies that have looked at giving beta-lactams to patients with reported allergy, the risk of an allergic reaction has been higher in those patients that didn't report an allergy, the patients that had unknown but severe reactions to beta-lactams. We overuse vancomycin in particular, and I will just tell you that when you look at the imported risk of allergy and surgical site infection risk, there have been a couple of these papers now that have shown the same thing, that if you give vancomycin, the risk of surgical site infection is higher, at least if you give vancomycin alone. So the increased risk of SSI risk in these patients was entirely mediated by the patient's receipt of an alternative perioperative antibiotic. For most patients, beta-lactams are the antibiotics of choice to prevent surgical site infections. They're more effective, they penetrate the tissue quickly, they're bactericidal, they kill the bacteria, and for most patients, they are the antibiotics of choice. There are a couple of exceptions. But I will tell you in a moment, for a variety of reasons, that if you decide to give vancomycin for prophylaxis, if one of my orthopedic surgeons calls me, I recommend that they give it along with the beta-lactam unless the patient has a beta-lactam severe reaction, and we'll talk more about that. What about screening? We talked about those microbial factors. There are organisms on the skin. Really good data is shown for quite some time that if the patient has Staph aureus, if you screen them, nose, groin, wherever you want to screen them, they're at substantially greater risk of surgical site infection, and it's likely that that surgical site infection will be due to Staph aureus. Note I said Staph aureus. I didn't say methicillin-resistant Staph aureus. It's both, methicillin sensitive or methicillin resistance. And there have been some good studies, I'm not going to go into them now, that have shown that if you decolonize the patient, you reduce the risk of a surgical site infection. Well, I know I've been talking with Dr. Robinson about this. What about universal decolonization? Because I know Phil was telling me that in California, I guess you're required, mandated to do MRSA screening of your patients when they come into the hospital. And for a certain reason, I think knowing whether a patient, particularly going to orthopedic surgery, is MRSA positive is really important. But remember, the vast majority of patients who are colonized with Staph aureus are colonized with methicillin-sensitive Staph aureus, not methicillin-resistant Staph aureus. About a third of the population, if you just go out in the general population and culture noses, about 1/3 of the population carries Staph aureus in their nose. And remember, we've already shown that those patients are at high risk of surgical site infection due to staph. Depends on which study you read, 1% to, I usually quote 4 to 8% of the patients that I see in the hospital setting are colonized with methicillin-resistant Staph aureus. Phil, do you know what your positive rates are for your just general screening that you have to do? 2%. Yeah, so if you just take your general hospital population, 2% come in that are MRSA positive. So much, much smaller percent. But remember, Staph aureus colonization is associated with a higher risk of surgical site infection. So if you just screen for MRSA, you're going to miss the majority of patients that have Staph aureus colonization. So I think if you're going to screen, you need to screen for both because you should treat them differently. But I also say if you go to universal colonization and you don't do any screening at all, but I know in California you have to, but in a lot of states you don't, I personally want to know if the patient has MRSA. I presented this study at ICCAC a couple of years ago. It was orthopedic surgery patients who had all undergone MRSA screening, nose, throat, and groin, So they had 3 sites. All of the positive cases underwent decolonization with mupirocin 3 times a day for 5 days. And at that time, they were using Clinisan body wash for 5 days. But they did not let them go to the operating room until they were screened negative. So these are patients screened positive, decolonized, could not go to the operating room until their screens were negative. Guess what? Most of them who got an infection with methicillin-resistant Staph aureus. And there are other studies that are similar to this. 4 out of the 6 patients who got an infection had MRSA. So I want to know if somebody's positive with MRSA because I changed my prophylaxis in a patient that's had a history of or is colonized with MRSA. So this is a study that I was on the design team with. It was a funded project by the Agency for Healthcare Research and Quality done out of the University of Iowa that looked at a bundled intervention. We looked at patients undergoing cardiac, hip, and knee surgery. And this was the algorithm, essentially. All patients were screened. If they were MSSA positive, so methicillin sensitive, which if you remember is going to be the majority, they all got daily CHG bathing, mupirocin nasal application for 5 days, but they got cefazolin for surgical prophylaxis. If they were MRSA positive, they got the same bathing and mupirocin application for 5 days, but they also got vancomycin in addition to cefazolin for their prophylaxis. Notice we did not remove cefazolin. We continued cefazolin, so they got both. And then if they had a negative screen, they got preoperative bath or CHG and cefazolin for surgical prophylaxis. What we showed in the study, this was the STOP SSI trial, there was a marked reduction when they followed the protocol in the risk of Staph aureus surgical site infections with screening and modification of the antibiotics. The number of patients who developed MRSA surgical site infections went down dramatically. However, you think, well, that doesn't look that impressive. I mean, it was about a 10% absolute drop in the risk of surgical site infection. Why didn't they do better than that? Well, it's because the teams didn't follow the protocol. So we actually looked at whether they were fully adherent to the protocol, partially adherent, or not adherent. And you can see 20% of the teams weren't adherent at all to the protocol. The rate of SSI dropped 75% in those centers where they stayed completely adherent to the protocol. But the rates did not decrease significantly in those groups that were partially or non-adherent. Only about a 20% change in their risk of infection. And sadly, there were quite a few teams that were up here in the partially or non-adherent groups. So, if you're going to put a bundle into place, one of the things I'm doing in my 3 hospitals now, if we put bundles, pathways into place, we're now doing accountability audits to make sure people are actually following them. There are other things, I'm not going to talk about the other agents. The agent that's been studied the most for nasal decolonization has been mupirocin, but there are some other interesting new products that are out there. There's the alcohol-based product that seems to be pretty effective. I will tell you, when we were looking at the literature on skin decolonization, alcohol's very effective. Alcohol kills bacteria really quickly. So I think it's an interesting product. There aren't a lot of studies out there. Ed Septimus did a very nice review of the 3 different types. There are some nice orthopedic surgery studies using povidone iodine-based nasal decolonization also. So I think now we're going to have multiple different options to use for that nasal decolonization when you have that patient that's positive. I'll tell you just very briefly about the CDC guideline. This was a labor of love. It took us almost 7 years to complete the guideline. It is grade-based, if you know what that means. We had to do a detailed review of all the literature, do an evidence review, and grade the level of evidence for everything. We had a big group. I was one of the 2 HICPAC leads for the guideline. The American Academy of Orthopedic Surgeons, AAOS, was definitely a participant in our guideline. And particularly in the section where we looked at orthopedic surgery. We use the grade methodology, and the categories of recommendations come basically, remember 1A and 1B are typically things you should do. Category 2, it's unknown. And I have to tell you, in surgical site infection prevention, a pile of things are unresolved. So when we started, we went out to the community and said, what do you need us to look at? So we had a core section, and then we had a section that focused only on arthroplasty operations. And these are the key questions that were answered. Does giving a transfusion increase the risk of a surgical site infection to orthopedic arthroplasty patients? What about the patients that come in? You know, it's probably fairly common that patients with things like rheumatoid arthritis or others that are immunosuppressives have to have orthopedic surgery. Anticoagulation, DVT prevention, does that increase the risk of infection? I love this section. I love looking at this data. What about the space suits? You know, those great, I don't know if you guys use them. Do they make any difference? Antibiotic prophylaxis, how long should you keep them on antibiotics after surgery? And then what's the role of biofilm? I will tell you, there's tons of research being done on biofilm around periprosthetic joint infections, but at the time we reviewed the literature, there wasn't anything we can say. I'm just going to run through these really quickly because I will tell you that for all but one of the categories, we gave no recommendations, unresolved issue. Transfusion, clearly certain populations, particularly pulmonary critical care patients, when you transfuse the patient, potentially has the risk of increasing the risk of infection. But we found no evidence in orthopedic surgery that transfusion increased the risk of periprosthetic joint infection. And our basic recommendation, if the patient needs a transfusion, if they really have good criteria to be transfused, give them a transfusion. Immunosuppressive therapy, should you stop it before surgery? We found no evidence that it changed the infection rates. Are immunosuppressed patients at greater risk of infection? Yes. Does stopping the immunosuppressive make any difference? We found no evidence that it did. Also, DVT prophylaxis, everybody worries about clots in the wound. I understand that, but we didn't find any good evidence that it changed risk of surgical site infection. I'm kind of a skeptic around all the different things that we do around the things we wear in the operating room because we found no evidence that doing the total head-to-toe coverage, it provides great protection to the orthopedic surgeons from splash. So definitely get that. Keeps blood off of them and things like that, protects them. Doesn't seem to make any difference in terms of the patients. And interestingly, a couple of the studies showed that it increased the infection rate when you wore the complete spacesuit, possibly because it's easy to feel like we're really protecting the patient. You know, our technique isn't quite the same. The only one that we gave a recommendation for was stopping antibiotics when the incision closed, and I'll talk more about that. The American Academy of Orthopedic Surgeons didn't like that recommendation and did not endorse that one, but that's the only one that there were randomized clinical trials that we could hang our hat on. And again, biofilm, we didn't make any recommendations. Here's the problem for those of us that are writing guidelines on surgical site infections. So if you ever get the chance to work with the CDC on a guideline, plan to read a lot. Because we reviewed 5,487 articles. We only found 170 studies that had quality evidence that we could incorporate into grade tables. There are piles and piles of poorly done, incorrectly done, single-site studies, industry-sponsored studies, other things that really limited our ability to do evidence-based reckoning. That's why in the guideline there are so many things that we had to list as largely unresolved. There's been a big conversation about this because for those of you in the room that are surgeons, you're going to make decisions about your patients and what you're going to do. And as we're updating the guidelines, we're saying, you know, sometimes there is some general consensus about the best things to do, even though there may not be a randomized trial. There are lots and lots of observational studies. And so we have to come up with some recommendations for the things, at least the best knowledge that we have available. But if you look at the literature in surgical site infection prevention, sadly, there just aren't a ton of RCTs that are available. A couple of things I'll just mention quickly. Give the antibiotic before the incision. How quickly or soon before the incision? Some people insist that the whole drug be in the patient, some don't. Again, remember, as Patrick Dollinger always says, the risk of a surgical site infection doesn't go from 0 to 100 the minute you touch the scalpel to the skin. In fact, the risk may be greater at the end of the operation when the wound is avascular, it's getting cold, and other things. There actually are a couple of studies that are relevant. In vancomycin in cardiac surgery, the risk of infection was lowest in patients that received the dose in the 16-minute to 60-minute time frame before the incision, so closer was better, even though oftentimes in those patients that it was started 16 minutes before the incision, it was not done. And then there's a large observational study looking at surgical infection risk in patients who got IV antibiotics, usually beta-lactams, and 4 minutes was the time frame that seemed to have the lowest risk of infection. I don't know that it matters a great deal. I say soon before the infection. I personally don't think the entire dose has to be in the patient at the moment you touch the scalpel to the skin. The one thing I do know is that a lot of the antibiotics that we commonly use for surgical site infection prevention have very, very short half-lives. So the farther you give it before the incision, the more likely you're going to need to redose it in the operating room, because multiple studies with tissue biopsy have shown that if you give a drug like cefazole and cefoxitin early, much before an incision, there's no antibiotic left in the patient when you close the skin. So it's controversial about the best moment to give it before the incision. In the CDC guideline, we made no recommendations about weight-adjusted dosing and intraoperative redosing only because there are no RCTs. I will tell you multiple other guidelines actually do recommend weight-adjusted dosing and intraoperative redosing, and I'll show you those guidelines in a moment. Antibiotic duration, we gave a category 1A recommendation because of all of the RCTs that show no benefit from keeping to give antibiotics after surgery. Is there an RCT in every type of surgery? No. Are there a lot of RCTs in every type of surgery? No. And that's where the American Academy of Orthopedic Surgeons came back and said there were only 4 RCTs that were quoted for orthopedic surgery, and they didn't feel like that was enough RCT data to recommend against giving antibiotics post incision. I will tell you that there are some very, very large registry-based observational studies coming out that have shown the same thing, that giving antibiotics after surgery don't make. I think there's going to be a lot more literature coming soon. Glucose control. If you're having problems with surgical site infection in your patient population, look at glucose control, because elevated blood sugars increase risk of surgical site infection. What level to target? That's controversial, the CDC guideline. This was a political decision to avoid hypoglycemia, so it's at 200. Other guidelines give you stricter targets. I typically target around 140. I'm not trying to do strict control below 100 or anything like that, but in that 140, 180 range to try to get the sugars down. Multiple studies have shown across multiple surgery types that the risk of infection is higher in patients that are diabetic, but also in patients who don't carry the diagnosis of diabetes, particularly in cardiac surgery, where they become hyperglycemic postoperatively. So again, I've highlighted arthroplasty, a 20% increased risk of surgical site infection, in spinal surgery, a 66% increased risk of surgical site infection in diabetic patients. So if you're having a challenge around surgical site infections, don't forget blood sugar control. Perioperative normothermia, I don't know what your protocols are here, but we recommended with a strong recommendation that you keep patients warm in the operating room unless it's an operation where you need to do controlled hypothermia. We know that some neurosurgery, cardiac surgeries, you do that. And oxygenation, relatively simple to do. If the patient's general anesthesia intubated, has normal pulmonary function. Why that population? Because that's the only population that's been studied. Then increasing oxygen, both in the operating room and postoperatively, has been shown to reduce surgical site infections. So most of the studies have used 80% inspired oxygen during the surgery and kept the patient on things like non-rebreathers for a few hours postoperatively. Oxygen, all you're trying to do is get more oxygen-free radicals in the blood that may kill bacteria. This is one that's controversial. Susan Wong probably doesn't agree with this. In patients, just the general population that comes in for surgery, should they all get CHG baths before surgery? I think the evidence is increasing that a lot of patients are colonized with bacteria, but we didn't find any evidence that CHG was better than soap and water for taking a bath before a patient went to the operating room, unless they're colonized with Staph aureus. Then definite benefit. The other big unknown area is, what do you do if the patient has a known history of an MDRO, some other infection, multi-drug resistant organism that they have been infected with in the past, or they're in the hospital? There are no studies, but here's another patient population where I would be quite aggressive with both skin preparation preoperatively and in the revised guidelines, I think it's likely when we revise the 2013 guidelines, we're going to say to tailor your antimicrobial prophylaxis to address some of those issues. Intraoperative skin prep, I don't care whether you use CHG alcohol or povidone iodine alcohol, or you do the old triple prep, iodine, alcohol, iodine, I don't care what you do, just make sure alcohol is part of it. If it's possible, alcohol kills bacteria really, really fast. I think it's part of the reason, at least these preliminary studies with the alcohol-based nose decolonization products are so effective. Alcohol kills bacteria really fast. The other one I'm going to talk about a little bit is irrigation of deep tissue. The only studies we found that suggested benefit was in spine surgery. And in those old studies, they were using aqueous iodophore solution to irrigate the wound. We found no evidence in abdominal procedures that irrigation with any antiseptics or anything made any difference. But in spine surgery, it was limited. We gave it a category 2 with very limited evidence. I'll talk more about irrigation in just a moment. So when we went through the guideline, these were all of the no recommendation unresolved issues, because there were no published randomized trials. All of the orthopedic key questions except antimicrobial prophylaxis duration, we found no randomized observational studies, and we could only review observational studies. Probably doesn't affect orthopedic surgery too much, but triclosan-coated sutures are recommended, particularly in abdominal surgery, colorectal surgery. I won't spend too much time. What about topical antibiotics? So this is one of the lessons I learned about reading meta-analyses. Should you put antibiotics in irrigation solutions? And does topical application of agents, which most commonly is vancomycin, doesn't make any difference? I will tell you all current guidelines recommend against it. I think the risk is relatively low, although we expose the environment to extra antibiotics. But I think the literature supporting it is very, very weak. And so we don't recommend it. And here's a couple of things. So one thing I learned about writing guidelines, meta-analyses, you got to read them really carefully. And you need to read all the articles that were pulled into the meta-analysis. So there was a general, it was a antimicrobial prophylaxis guideline written by a group of general surgeons out of, I think, Pittsburgh, that came up with this recommendation for antibiotic irrigation and topical antibiotics. And when we reviewed their study, what we found was that these studies had showed some benefit of antibiotics in irrigation solution or topical antibiotics. When you read the individual studies inside of the meta-analyses, they compared antimicrobial irrigation or topical antibiotics to patients who got no parenteral antibiotics at all. So our thing was, for sure, if you're not going to give the patient IV antibiotic, yeah, it helps. But when we looked at those studies, when we limited our research to those studies where the patient received appropriate intravenous antibiotics, adding on the irrigation or topical stuff made no difference. So my point is, make sure you're doing your prophylactic, your intravenous parenteral antibiotics appropriately where it makes the most difference. And I will just tell you, we saw a lot of meta-analyses that were, the meta-analysis was done from a statistical standpoint correctly. They pulled the data and did all the statistical part of it. But they didn't have content experts that reviewed the papers that they pulled into these meta-analyses. And some of them, you know, the biggest problem with the ones that meta-analyses on duration of antibiotics, they often pulled in different studies that compared two different antibiotics that had different half-lives. You can't look at duration studies when you're comparing different half-lives on antibiotics. So this was a paper that was just published in June that I thought was interesting, looking at vancomycin powder. And they showed some benefit of vancomycin powder in these patients, but they also showed that they had an increased incidence of gram-negative and polymicrobial SSIs when it was used. So you may end up with more resistant organisms causing your infections. So that brought me back to a study we published a few years ago. This was looking at all the NHSN data from 2006 to 2009, and these are actual infections reported to the CDC for coronary bypass surgery and hip and knee arthroplasties. And all we did was report on the microbiology of those infections. And of course, as you would expect, MSSA and MRSA were the most common, just under 40% of the 34% of the infections reported to CDC were gram-negative, which kind of surprised us. So it's part of the reason when the orthopedic surgeon calls me about a patient that may be MRSA positive, I won't recommend vancomycin alone. I will always couple it with cefazolin or other agent if I have to. But I don't recommend giving vancomycin alone because you're going to miss a bunch of organisms that can cause surgical site infections beyond the staph and strep species. I'm not going to talk about the Shea Compendium. This guideline is now undergoing updates, but this provides a practical approach. It's not grade level evidence. It's kind of the practical thing. It's written by clinicians, surgeons, infectious disease doctors, infection preventionists play a big role in this guideline on what you should do day to day to prevent surgical site infections. It's kind of the practical guide to prevention of infections. Also, the World Health Organization has published guidelines, and the American College of Surgeons and Surgical Site Infection Society have published guidelines. So what did they say that might be relevant to orthopedic surgery? Again, WHO gave 9 strong recommendations, but again, known carriage of Staph aureus should receive. They used mupirocin specifically in their recommendations, but again, that was before some of the newer studies with or without a combination of CHG body wash. Hair should not be removed, or if absolutely necessary, only with a clipper. Surgical antibiotic prophylaxis should be given before the surgical incision. They said within 120 minutes, based on their review of the literature. And again, I don't have any problem with that, but if you're using a drug that has a half-life of 2 hours and you give it 120 minutes before the incision, you need to redose them when you make the incision. That's part of the problem. Surgical hand prep should be performed with either antimicrobial soap and water or alcohol-based hand rub, no difference. Alcohol-based antiseptic solutions based on CHG, they focused on CHG specifically for surgical site skin prep. So the one commercial prep there, I think, is ChloraPrep. But I think the povidone iodine alcohol prep works just as well when you can't use CHG. They also recommended giving oxygen, 80% inspired oxygen intraoperatively, and then if feasible for 2 to 6 hours postoperatively. Again, relatively, why 80%? Because nobody's ever studied 50% or 40%. All the studies that have been published used 80%. We don't know whether you need to give 80% inspired oxygen. Should not be prolonged after completion of the operation. The ACS, a couple of other things. If you can get the patient to stop smoking before elective surgery, it probably reduces the risk of surgical site infection. And again, the American College of Surgeons recommended Staph aureus screening depending on your baseline SSI and MRSA infection rates. One of the first things I ask when a hospital calls me and talks about their problems with an infection rate is I want to know if the organisms they're telling me about are based on their antibiogram in the hospital or whether they're doing explicit surgical site infection surveillance. Because I've seen, University of Washington was one where if you looked at their antibiogram, the vast majority of the Staph aureus that were on the antibiogram, which is heavily driven by your ICU population, were methicillin resistant. When they looked at their surgical site infection specific surveillance, most of their Staph aureus infections were MSSA. So I just highlight, if you're having a challenge, focus on your surveillance on those infections that are actually causing surgical site infections. Here's what the ACS said about glucose control. They targeted 110 to 150. They explicitly recommended antibiotic weight-based dosing and redosing based on half-life for 1,500 milliliters of blood loss. Most of the rest of their recommendations are for colorectal surgery. What should you wear in the operating room? This is my favorite debate. Should you wear skull caps or other things in the operating room? Not long after I gave this last talk, Joint Commission came to our place, and we passed with flying colors, and then we had a validation survey by our state health department 2 weeks later, and they found some surgeons with skull caps, and the state health department went nuts about it. Maybe wear nothing at all. Naked surgeons shed fewer bacteria in the operating room environment than ones wearing surgical scrubs. So just saying, if you want to really shake things up in your operating room. Finally, I'm going to talk a little bit about, remember I showed you the STOP SSI trial, and the one thing that really caught my attention from the STOP SSI trial, and one that I'm really focused on in my institutions now is, are we adherent to the protocols we put in place? We've got to make sure the protocols are correct, are evidence-based, but do we hold people accountable for doing it? Because in the STOP SSI trial, they found that the reduction in infection rate in those centers that were adherent to the protocol was 75%, but it was only about 20% in those that were either partially or non-adherent to the protocol. We've published papers, there have been other papers studied that basically show that if you put a bundle into place and you adhere to it, you reduce the risk of surgical site infection. In this colorectal surgery study, I'm not going to show you the data, but they had 6 different interventions, and the risk of infection dropped from about 18% if you only did one of the bundle items down to about 2% if you did them all. So it was a stepwise progression that the bundle really made a difference. And there have been nice meta-analyses. This is a big one of 8,000 patients showing that bundle adherence makes a difference. But there are also starting to be some published bundles in orthopedic surgery. I didn't agree with all of the things that they put in their clinical pathway, but there too, what they found was that if you implement the bundle and you hold yourselves accountable to the bundle, you can reduce risk of surgical site infection. Well, we have a lot of work to do. This is data from NHSN, the 2017 report that showed for hip and knee arthroplasty in the U.S., we've seen essentially no change in rates of surgical site infection. The standardized infection ratio, remember 1 would be your infection rate is exactly what would be predicted. Hasn't really changed much. It's gone down a little bit for knee arthroplasty, went up a little bit for hip arthroplasty. Again, I think we're going to see a more complicated population of patients having orthopedic surgery going forward as we do more revision surgery. So I think we're going to see probably be treating some difficult patients in the future. But you can see across the board, statistically, even though we're doing lots of things around surgical infection prevention, the numbers aren't moving very much in the U.S. So I've learned a lot of things through the process of developing guidelines. I've read a pile of papers, and I've had the opportunity to talk to many audiences. There's just not a lot of really what I call high-quality evidence on prevention. There just aren't a lot of RCTs. So Phil and I had talked about that I think the American Academy of Orthopedic Surgeons and their foundation were getting ready to start a randomized controlled trial of stopping antibiotics in the end of the operation versus continuing them for 24 hours. I searched and searched from clinicaltrials.gov yesterday. I can't find it listed. I can't find that study has started or anybody out there is actually doing it. There just aren't. There's some big observational studies coming out from registries, but there's just not a lot of RCT evidence. The other problem I have with a lot of these, so part of the reason I actually contacted my friends at Duke and said, is there a randomized trial of duration in orthopedic surgery? Because my big thing is make sure we standardize what happens between the two groups and that we control for those other risk factors known to account for surgical site infections. Do we do glucose control? Do we keep the patients warm? Do we give them the antibiotics in an appropriate weight-based dose and then at the right time? Beware of the meta-analyses. While they may be methodologically done very well, the studies that are included in the meta-analysis may have major flaws. And I see it at my own university. So everybody wants to publish a meta-analysis. All of the biostatistics epidemiology programs across colleges of public health, like the one I teach in, they teach them the methodology, the statistical methodology. They do that part of it okay. What they aren't is content experts about the studies that they're including in the meta-analysis. So you just have to take that with a grain of salt. I think for some topics, we may never have really well-designed RCTs. I was just thinking about if we're going to do a randomized controlled trial in the United States of orthopedic operations, let's just take hip arthroplasty, which is a really common operation. It's going to be a really, really big problem to compare stopping at the end of the case versus 24 hours because the risk of infection is very low to show substantial reduction or change or non-inferiority. It's going to take a whole lot of patients in that study to demonstrate that. So I question whether for some things that we have questions about we'll ever have well-designed RCTs. And while I understand the need to do industry-sponsored studies, it takes points off in any grade methodology. So in conclusion, surgical site infections are the most common healthcare-associated infections in hospitals today. I think they're much more common than we report to NHSN. I think a lot of things don't get reported. Risk of SSI varies by operation type. Clearly, colorectal surgery is a huge issue. Orthopedic surgery, hopefully, we keep our rates very low. And I think as we see more revision joint arthroplasties in the future, as patients age and live longer, we're going to see more infections. Multiple risk factors that contribute to the development of SSIs. It's why you won't hear me chase zero too much on surgical site infections, so there are a bunch of them out there that are preventable that we need to do a better job on. It's been a great pleasure to be here today. I'll be happy to take any questions.